This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Brooke LaLone Ward. Brooke is a licensed marriage and family counselor who has grown up and lived in the Finger Lakes region her whole life. She has recently delved into neurodiversity after finding out her own neurodivergence in the fall of 2022. As she was navigating what it meant for her, she expanded her practice to specialize in neurodivergent couples and trauma therapy. This is an expanding and much-needed space. It's real, and Brooke is on a mission to normalize it for others and herself for a lifetime of trying to keep it all together. Brooke has a private practice, is a provider for Golisano's behavioral health, and a neurodivergent trainer and advocate with a passion for engaging the community to broaden our understanding of neurotypical so that everyone has access to compassionate care.
Welcome, listeners. It's great to be here today. We have an incredibly informative and engaging show for you. And I want to tell you that our podcast is sponsored by two amazing eating disorder nonprofits. The Emily Connection, founded in memory of Jack's and my daughter, Emily Major, and KMB for Answers, founded in memory of Ellen's daughter, Caitlin Bennett. Our special guest today is Brooke LaLone Ward, and she will be with us in just a minute. But first, I'd love to welcome my co-host, my husband, my soulmate, Jack Major. Is that your name?
It is, yes.
And our dear friend and fellow mental health and eating disorder advocate, Ms. Ellen Bennett.
Well, Linda, it's great to be here again, and I'm so excited about this topic today of neurodivergency because I've heard it so much, and I really wanted to learn more about it. So, thank you, Brooke, for being here today, and thank you, listeners, for being here today also.
Welcome and hello. So glad to be back. I met our guest, Brooke, about 2 years ago when a mutual friend connected us, and we realized how we have shared commitment to raising awareness about mental health and eating disorders. I have had the opportunity to watch Brooke grow into her practice and expand as she follows her heart and passion to help the neurodivergent community. I am fascinated by her work and her determination to make a difference. I've learned a great deal from her and continue to do so. I have the honor today of sharing the quote. Woohoo! Neurodiversity is not a defect. It is a beautiful variation of the human experience. Steve Silberman. I love that.
Yeah.
I do too.
Yeah.
It's beautiful.
Maybe we could all think of each other as part of the beautiful human experience and embrace everyone.
Well, it's our differences that make us more interesting, right?
Mm-hmm.
Yeah.
Yes.
And the gifts that others have that maybe we don't have quite so much, we really should appreciate and applaud them.
Absolutely.
They help us grow and round us out. Welcome, Brooke.
Thank you. Thank you. That was such a lovely and warm welcome. It's an honor to be here. And we all are neurodiverse.
I just want to remind our listeners that the links for today's show will be in the show notes. So, Brooke, you ready to roll?
Absolutely.
Okay. Well, we're thrilled to have you here. Can you share a little about your early life's journey and when you knew you wanted to pursue a career as a marriage and family therapist?
Well, a big, broad question. I will warn everyone with my own neurodivergence, with my ADHD. Sometimes I jump around a little bit, so please pause me if I'm not making sense or need me to slow down.
We never do that.
Well, this first question had me reflecting for a few days on it, where, I'll start with, way back in early life, I really didn't have, I guess, a dream career aspiration, especially being a marriage and family therapist exactly. But I think it, reflecting way back, I came from, in childhood, a fairly chaotic and turbulent home. I think from an early age, I was always fascinated by people, interactions, feelings. At the age of probably 5 or 6, I remember there was a VHS tape of whatever the book is, Women Are From Venus, Men Are From Mars, or whatever. And I was just so fascinated, and I think we had the book too, and tried to read it, but at that age didn't make sense. But I knew just from that, I didn't take it literally. I could tell, men are different, so are women, and I want to learn more. And I think a lot of that stemmed from wanting to understand, specifically a parent of mine that had, I think, struggled with a lot of mental health issues, and knew that was not the normal compared to my friends. But fast forward into, I think, middle school in a home and careers class, I know that was the question of what do you want to be when you grow up? And I think I wrote down the word psychologist, and I don't think that word ever crossed my mind before. It just came out of nowhere, and I didn't think of that term ever again when selecting college. I went into general liberal arts and eventually landed in the psychology major, but still didn't really know what I wanted to do until the last semester of undergraduate school. It was always between maybe a teacher, a nurse, school psychologist, social worker, but nothing ever landed until I fortunately met a really awesome professor that helped to guide me and show me my strengths and helped to understand what a marriage and family therapist really did, and said that my line of thinking landed with it, and my childhood experiences that I shared in his class pointed me in that direction, and ended up here in Rochester at the University of Rochester. And amongst that, similarly, as all of this was going on, I did have a very special interest in eating disorders. And I believe, looking back, had my own struggles with food and body image, being a cross-country runner and a marathon runner, and a female athlete. I can see I had a lot of struggles, but never was professionally treated for it. But did a lot of research in undergrad and in graduate school to kind of help inform my care after that, and ended up working at the Healing Connection here post-graduation. So that's a little bit about all of that.
And where did you go to undergrad?
Keuka College.
Keuka. Okay.
Oh, that's a beautiful
spot.
Beautiful school.
Yep.
Yeah, beautiful.
And where did you grow up?
I grew up in Adams, New York, so about a half hour south of Watertown, New York.
Snow country. Mm-hmm. Yeah. So can you tell us now about your practice and where our listeners can find you?
Yeah. I work for myself in my own private practice. I'm located in Webster. I also offer virtual services to anyone located in New York State. And you can find me at my website, brookewardlmft.com. And also, I believe it'll be in the show notes, my email and probably social media accounts as well.
So you have in-person groups in Webster?
Yes, in-person, individual, couple, and family therapy.
Okay. And where's the address for that?
1681 Empire Boulevard, Webster.
Okay.
That's great.
Great. It's great that you have so many different, options for people to contact you and listen to your wonderful, wonderful advice.
Thank you.
Okay. More and more we're hearing neurodivergent. And I attended one of Brooke's trainings because it was on neurodivergent. And I was like, okay, I need to know more, because I just really felt like I didn't have a good baseline at all. And to make the connection between that and eating disorders and just in general. So I'm going to ask you to please explain to all of us what that means and how it applies to your work. Help us have a better understanding.
Yeah. And I know that I believe you said this in the training initially, where you said, like, yeah, what is neurodiversity? I see it everywhere and on social media. And really the broad term is, meaning we all have different brains, or individuals who are neurodivergent aren't considered neurotypical, or maybe process things or function in the neurotypical standards that our world really is operating off of. And I really have applied it personally once getting my diagnosis, as said in the introduction. But it's helped me to see it from a different lens from all of my clients. Neurodiversity affirming care really tries to challenge and reform the current systems stemming from westernized medicine, the medical model, which a lot of people find that can be really negative, stigmatizing and pathologizing for a lot of mental health disorders and conditions. So it really helps me to shift my perspective and be even more open and curious and let the client be the expert in the room. Because sometimes most of the time.
That's a novel concept.
Yeah. The medical model states that really there's that power dynamic of the provider professional in the room is the expert. And, what the treatment model says, we really have to adhere to it. Versus having a client, be open and say, it's not working for me. It's allowed me to pause and be curious and compassionate and find the right approach and tools to help this person with what they're saying to me. It helps build a level of trust, I think, in a deeper level than, again, maybe some more of the traditional modalities.
The cookie cutter. Yeah.
Yep.
I have to say, the more I learned about it, the more of an awakening moment for us. And it's just such a huge concept to kind of take a step back and look at the broader picture and take in a little more information on, as this grows and expands, it's going to be powerful shift.
Yeah. And I like to give a visual or a metaphor to help listeners kind of understand really what neurodiversity really might mean, or a neurodivergent brain. Because I know we commonly hear it now. It's a very common social media or TikTok trend, and I feel like it can be easily dismissed or invalidated in and of itself, because it's true, we all do have different brains. And but if we were to think of it in the way of picturing a neurotypical brain and what that looks like, that would be like if we were to take 50 brain scans of neurotypical brains and maybe put them all on the wall and look at them and even put them over top of each other. They would look all very similar. They would have the same, very similar densities. The brain regions would be the same size and in the same place. But if we were to take 58 scans of neurodivergent brains and look at them on the wall, they would all look like snowflakes in a way. Some of the regions might be bigger, smaller, maybe not exactly in the same place of a neurotypical brain. They might have different densities. Like for an example, an autistic brain, research has shown that they can be upwards of 3 times more dense with brain matter, neurons, than the neurotypical brain. So I just like to highlight that there is visually literal differences in some of these brains.
It's a great visual to share with us.
It really is.
Yeah.
And in a way, who wants to be typical or ordinary?
Yeah.
I mean, I think some of the brightest people on this planet are people who think outside the box and think a little bit different.
Yeah.
So there's a place for all of us.
Absolutely. We're all neurodiverse, as I said. And I think actually the majority of people in this world fall in the neurodivergent category, but neurotypical brains, there's just so many more of like the sameness together. If we were to think of it in a bell curve, they would be in the middle, and there'd be many more outliers towards the end of the bell curve. Mm-hmm. But
is it a heredity factor in the brains?
Yeah, from what I've read it's between sometimes 90-95% chance. For example, if a child, I think a lot of people are receiving late adult diagnoses of like ADHD and autism because of that factor of heritability with those, given it is a genetic difference.
Wow. Well, I'm going to move on to the next question. Are you ready?
I'm ready.
We certainly understand that one size does not fit all when it comes to finding new pathways to healing. It must be challenging working with patients with several mental health issues and with those that have experienced trauma. The language we use and even our tone of voice is so important in helping people feel understood and safe. Can you speak about those things as a therapist?
Yeah, absolutely. So, I'll start with especially the several mental health issue piece here. I think if we think back to the traditional medical models, the DSM-5 specifically for mental health, I think clients can get a large list of diagnoses when they come into therapy. One, I think because it's fairly subjective of what the professional is assessing for, what they see. And then also, if undiagnosed neurodiversity is in there, can cause just a whole conglomerate of different presenting factors of a client that comes in the room, on top of most likely also having trauma, being a human. It can be hard and challenging, I think, for a lot of clinicians that are the cookie cutter clinicians to work with clients that present that way. Again, I try to find many different modalities to help clients, but I think it really starts with just like treating the person as a person. How I do it in our sessions, even before I meet the person, usually I connect via email or by phone, just to get the initial contact or consultation, but just even ask them, sensory-wise, which is a big theme in neurodiversity affirming care, like what can I do to make you feel safe coming into my office, such as, I have some clients that are very sensitive to smells. Do you need me to make sure I don't plug in my Glade plug-in or light a candle or have essential oils going? Do you prefer if I don't make eye contact with you? Would you prefer if we, if we're going to do a virtual session, do you want the camera on or off? Do you want my camera on or off? Would you prefer to communicate if you're talking about difficult things via almost like a sticky note, or send me an email prior to session? So, even before meeting them or trying to diagnose and assess for whatever mental health condition might be going on or their trauma, I just want people to feel safe to be there and be vulnerable.
Well, and it gives them the empowerment to be engaged in that, rather than, being afraid to walk in and, and maybe they've had so many bad experiences in the past, so that's wonderful to give them that option to choose.
And I love how you work with families, because our relationships are so important, and communication is the way we connect with each other. And I think we can all learn from each other when we're open and when we share. And I think as a therapist, you probably know very early on what form of communication is best for this person. And, would this person, or just repeating, I guess I should say, just repeating things back sometimes, how you're feeling. Wow, that must have been really hard, that's sad. And I think sometimes we just expect people to react the way we react, and they're different. So I think a therapist who works with the whole family and works on that communication is held in the highest esteem from all those people, because it just makes everything better and manageable.
Yeah, absolutely. Where we can only heal in connection and in a safe environment, where I think too, it's sometimes challenging just seeing an individual client and not having that family there, because we could do all the work, but it all happens in the family system.
Yeah.
Right.
Well, theme for Eating Disorder Awareness Week this year is healing in community. And yeah, we need a whole community. And that includes families, but it also includes, outside the families, friends, teachers, whatever, just the whole plethora of people.
And no matter what people are struggling with, it's important for them to find their voice.
Yeah.
And to be able to tell people, okay, that hurt my feelings, or no, that didn't work for me, because that's so much a part of what happens when people start to struggle and shut down, is they hold so much in. And usually there's a respectful way to get your point across. And sometimes we need help in doing that.
Absolutely.
They need to know they matter, that they matter. So I love this next question. I'm glad it's my question, because I'm very interested in the answer.
Well, you wrote it, right?
So, from your bio, we know that you're conducting neurodiversity training for clinicians. So I'm just very interested to know how receptive that is to the clinicians. And, I know there's, and I love this too, I know there's many evidence-based approaches to pick from, in quotes, evidence-based. But it must be challenging to know which ones and when to use them. But I'm just really interested in the clinicians' response.
Yeah. Well, it's a mixed bag where I've only had 2 trainings, and I think the people that come to the trainings are highly receptive and curious, and we have wonderful, rich discussions. And I feel, so excited to have other clinicians be on board, and their eyes are open and they want to make these changes. But I think the hard part is reaching practitioners, clinicians that don't have any interest in this. Of course, they're not going to show up to my training, but I'll use an example to highlight just, I guess, maybe how devastating for, clients, people trying to seek out legitimate diagnoses that can unlock a lot of treatment doors, such as medications or disabilities. Why I'm really passionate about trying to, have all types of providers at least listen to what I'm saying. Go back to fall of 2022, post my diagnosis, a few months later, I was working with a client that I had known for at least 2 years, and understanding my ADHD, I could definitely see it in her. And I always just thought it was just, she's stressed, she's a mom, it's anxiety. But, her and I talked about it for a couple of months, and she finally bought in, where she didn't even believe it was ADHD herself. But until, I gave her podcasts and books and resources to look into, and her and her husband finally were like, yes, we think this is what it is, and this is why none of her medication has ever helped. But then the next step was in order for her to access appropriate ADHD medications, so stimulants or non-stimulants, she needed a legal formal diagnosis from a psychologist or doctor or psychiatrist. And locally, I did not know where to look. I never really worked with ADHD besides for myself. And, I reached out to a message board online, and a few psychologists responded. She selected one of them, and I collaborated with the psychologist trying to discuss ADHD, and the psychologist, during the phone call, I could kind of get the sense that was not on board with me, because there's a lot of stigmas with ADHD meds, specifically Adderall. I think the psychologist thought my client was just med seeking. But long story short, the client went through probably about 9 hours of testing to get her diagnosis, and spent probably, I think it was around $7,000 to receive a formal diagnosis of adjustment disorder with anxiety, which in mental health terms, that's a diagnosis I give a person in the first session if I need to bill insurance and I really don't know what I'm dealing with. So I don't want to slap a really big label such as bipolar or anything like that if that's not accurate. So I just felt very defeated and devastated, especially for this client spending so much money out of pocket just to feel invalidated and not seen. And I believe, looking at the psychology assessment, there was only one test done for ADHD, and it was a it was a rating scale that's used on children. And so felt very, I felt guilty too of like, having this client she was really excited and empowered and finally felt understood with what was going on in her mind, and to have a provider give that answer back just felt incredibly invalidating.
Oh my gosh, I'm so sorry. So is there when you're having these trainings, the age of the clinicians, are the younger people that are more open to?
The first training, let's say, last column, like younger, I would say, more, for clinicians. But my last one, I had, I believe, 16 or 17 providers come, and it was a big spread of age. I had one psychologist in the room, and I was incredibly grateful for that. And unfortunately, the psychologist wanted the evidence base, like what are the assessments, how can I do this to inform my practice? And I could not give that to them, unfortunately, because a lot of it's not out there. It's a lot of just our own maybe lived experience, such as myself, to see some of these symptoms in a different light, or, knowing how to best assess.
I just think it's, terrible that, if we don't embrace other ways of treatment, it'll never be evidence-based.
Yeah.
What I mean? If it's not broadly accepted,
And to the evidence-based piece, I guess I should have known starting in graduate school that like my brain did not like a lot of the evidence-based stuff, which looking at it though, from a marriage and family therapist perspective, we don't do a ton of, traditional methods that maybe like a licensed mental health counselor or clinical social worker really are trained in, such as cognitive behavioral therapy, which is very standardized. But we do a lot of family systems theory, so we're working with family and communication. But when I was approached with some of these tools, such as cognitive behavioral therapy, I didn't understand how it worked in graduate school, where it's a worksheet typically of your irrational thoughts, and you write down how it's irrational and how to reframe it. And then I guess some people feel better when they say, yep, this thought's irrational. That'll never happen. Okay, my anxiety's gone. Where I was my brain, I was like, I have a dissertation why this thought is irrational, but I'm still feeling anxious and panicky and know that it's not going to happen. But that doesn't work for my brain. So I, as a clinician, just never really used those tools. But so like a lot of people want like a manualized thing to help support their clients, or how to assess or how to talk to a family if their child might have autism or ADHD or OCD. And unfortunately, those aren't out there.
Yeah, it always drove me crazy when I, as a pharmacist, I'd have to go to the CE, things, and somebody put up a PowerPoint, and it's 2020, and they're putting up a PowerPoint that's got statistics and all this data and stuff from 2006. And it's like, well, here we are in 2020. So you have nothing newer than 2006 to show us, and I guess that's the stuff that drives me crazy. I can remember doing consulting in a nursing home with a doctor and wanting to try patients on fish oil and stuff for their, for cholesterol, for their triglycerides and stuff, which, and the doctor would say, oh, that there's no studies. It's anecdotal, and,
So in other words, they just don't want to go there.
Yeah, right. So yeah, that's the frustrating part of, I know it's a big wide world of healthcare out there, and I just wish that, more would be more open to.
It's going to take time.
I know.
It's going to take these conversations,
but,
and really saying we have to listen more to the patient.
Yeah.
And we have to look at utilizing different methodologies and different techniques and just different research-based things, because to some extent I keep thinking we have to admit that maybe we don't have all the answers, and that's really difficult for a lot of people to say. And stepping out of the silos and saying we have to figure out a better way, because if we know nothing else, mental health is complex. It's multi-layered, multi-dimensional. Oh, God.
Well, everything,
Praying.
It's the practice of medicine. It's the practice of pharmacy. It's the practice, everybody. So, and I had one doctor tell me, if people knew how little we really know, they wouldn't hold us in such high esteem.
That's a very well-kept secret.
Yeah.
Well, I love that humility, though.
Yes.
And
he was a very good doctor, and, he helped a lot of people. But, they just can't stand on this pedestal like...
Well, and it goes back to the cookie cutter thing, right? You don't relate to every teacher you've ever had, yet some just fill you up and make you curious and want to learn more and more. And when working with people who are neurodivergent and people who are deeply depressed or are really entrenched in an eating disorder, it might take a few therapists, to find the right one, but it's such an important connection. It's just sad that there's such a shortage of therapists. I really do believe that in school that there should be therapy a couple times a year, just so children get used to having someone else that they can talk to about things that are going on in school. I just think that would be just a great way to keep our young people healthier and open and know it's okay to share.
Yeah, to be proactive instead of reactive.
Yeah. And trying to, in general, the mental health stigma, where I know for a lot of people, they see therapy as bad, or if my child needs to go to therapy, then I'm a bad parent or a failure, and just normalizing it's okay to talk to someone. And, there was a statistic in graduate school that I'm probably going to butcher, and if someone's listening from there, may be wrong, but I believe one of the very first classes I took, it was something along the lines of, what constitutes as successful therapy or a client-therapist relationship. And, it came down to 80% of the success rate really comes down to the relationship between the therapist and client. And it doesn't matter what the modality is or how often or
that's what I say
all
all
the
the
other
time.
things.
I say that all the time. The most important thing is the connection. The most important thing. And I know there's not enough therapists educated in eating disorders.
Yeah.
But I believe if you have a really strong connection with your therapist, they can learn what they need to help you because there's not enough people educated in this, that, or the other thing, going forward. And, there's times in our lives when we're all going to be struggling with different things, and just knowing that there's your people out there, right?
Yeah.
That you can find your people.
Yeah. Yeah. And I think it's once you have that connection, the client person can be vulnerable with this person and be really honest of what are the struggles, or, have a person be open and curious about it and not maybe invalidate it per the traditional medical models. And give an example of my own therapy prior to my diagnosis and 4 months postpartum. I believe it was around in the summer of 2022. Had a really great relationship even with this therapist, but from the neurodiversity lens, I felt incredibly invalidated in a really, really small way, maybe from this therapist perspective. But in session, I felt just confused and honestly ashamed, furious that what I was saying was not being heard. And, I was talking to my therapist about how I was having a lot of just overwhelm, anxiety, panic, and it kind of gets displaced back to well, you're in the postpartum period. It's postpartum. Or, I would say when my daughter would cry or scream, I would just get feel like I was on pins and needles, or I wanted to cry. And it was going back to, well, let's challenge that anxiety. Babies cry, Brooke. That's okay. She'll be okay. But I was I just didn't have the words to say, it's not my anxiety. I'm not having racing thoughts or worried I'm going to harm her. Something's going to happen to her out of the norm. But, fast forward a few months later, realizing with my diagnosis of ADHD, I was just having a lot of issues with overstimulation and sensory overload with her crying. And, it just would feel, like I was always on edge. And also, given postpartum, I didn't have routine or structure that I needed my whole life, where I thrived working and in school and with a baby. I was sitting around all day trying to feed her, take care of her, and that was it. And it was just.
And it changed every day. There was no structure every
sleep deprivation. Yeah. So, but kind of having a few sessions of just trying to, again, with the cognitive behavioral therapy approach, which I hated to begin with, challenging my thoughts just really didn't help me at that time. And, seeing it from the ADHD lens, finding the right medication for myself and just knowing that I'm going to have this reaction to her and still do to this day if she cries or the TV's on loud and the dishwasher's going and microwave is beeping. Like I still have that reaction, but it's not a cognitive mental health, I guess, per se, anxiety issue. So, but finding then later a therapist that could hear me and be curious about it and offer suggestions like, why don't you just put in those like loop headphones, earplugs that muffle the sound a little bit? That might help you. Here's a med that will help that. Just normalizing like, okay, that's okay. You're not a bad mom.
Your lived experience is really creating a very compassionate and safe space for others who really need somebody to listen and hear what I'm saying. I love this conversation, and generally there is a slow movement to taking into consideration more aspects of the individual in treatment. And I think we're at the beginning, but the conversation has started. And I say, thank goodness, because we have to look at different ways. And I know in reality, within treatment, and I'm going to say specifically with eating disorders, individual does not always follow the plan and can be resistant and not follow the expectation or respond to the therapy as prescribed. And often they're labeled treatment resistant. And when I heard that term, I was like, what? Coming out of education, and there are multiple measures, there are multiple approaches. Not everybody, it's like we need to expand. And also, in fact, there are underlying reasons why this individual is resistant and will not conform. But unless you ask the questions and take the time and dig a little deeper, you're not going to know. So, Brooke, continue the conversation. Yes. Expand on why this is so important.
Yes. Well, part of it, especially in the eating disorder community, as you all know, too, in higher levels of care of inpatient, residential, partial, there's constantly, I think, a lot of stigma and shame for the treatment-resistant clients, patients, and honestly, like working in a setting like that, having providers, sadly, like maybe make comments like a frequent flyer or she's back again. And like just even that, like that attitude, like, a client might not even hear you or patient, but like catch on to that. But in the neurodiversity lens, one, there's no assessment for really ADHD, autism. Sometimes there's some OCD. I think with especially anorexia, it's quite common. I hear like, that diagnosis is associated with it. But I think OCD, that's, a big indicator possibly of neurodiversity. And I think, clients that come into a treatment center anywhere between outpatient all the way up to inpatient, if the clinician, therapist, provider is not asking the right questions or being curious, clients don't know what they're struggling with because, there's statistics coming out right now that between 35 to 40% of those with anorexia have that likelihood of also being autistic. And, if we're ignoring the autism piece, because I think, one, there's a lot of shame and stigma with that diagnosis specifically and is often assumed to be a male type of disorder for a lot of different reasons. But with autism, it could be a lot of different ways of, struggles with sensory processing disorder that, often we hear autistic individuals that are diagnosed are labeled with ARFID, but maybe it's, genuinely they don't like the texture of certain foods that are being served in the residential facility or partial, and then they get labeled as that's just your eating disorder talking while you're not eating it. Or I have some clients, have sensitivities to things like high acidic foods, such as maybe like tomatoes or citrus fruits, and say like it just gives me a lot of heartburn, or they do have a reaction to it, but medically it's not. They could get tested for an allergy, but it doesn't come up as an allergy. But you put this type of food in front of them, and it does cause them physical pain or upset stomach, and it just gets kind of thrown into, well, that's your eating disorder. Oh, you want to go to the bathroom. That's your eating disorder, and it just invalidates their struggles. And, it does mentally, I think, they gaslight them of like, okay, I guess it's my eating disorder. I can't bring it up that it's a struggle now here in therapy. Or work around it, and then I might be seen as resistant, and I'm going to get kicked out. And we're going back to the cycle over and over and over again, where it can be just those minute things.
Yeah, I always think, and I always tell people, if I was in a residential treatment or wherever I was in the hospital, and they brought me, my dinner or lunch, and there was Brussels sprouts on there, I would say, I'm not eating those. And they'd say, well, you have to eat those. That's, and I would say, no, I'm not eating those. And, so I would be labeled, there'd be something in my chart, refused to eat, and it's just terrible. Terrible.
And in other facets, especially residential, for neurodivergent, for some folks, especially with autism, like having social differences or challenges, or sitting in a group therapy room with bright fluorescent lights and a bunch of people and have to share and be vulnerable, like that's a challenge. With some clients with ADHD, it's going to be backwards for a lot of therapists. Would not like this recommendation I'd give, but in order to eat, they need to be moving around or doing something. But in a treatment facility, you have to sit down together at the same table. Don't distract yourself. Eat all the food. But for some of my ADHD clients, they just need that movement and hyperactivity to eat their snack. It's like, okay, if you need to clean the kitchen and eat your apple and peanut butter, go for it. Where some clinicians might say they're just trying to burn calories.
Yeah, we were told by somebody that was, I think they were in the hospital, and they were standing at the window, and they were told you can't stand because you're just trying to, you got to sit down. It's just crazy. I don't know.
Yeah.
Crazy.
It is. And again, I'm going to keep saying it. Having these conversations is just so critical, because it's got to open the window, open the door to say, we need to look. There's the rate of relapse and the rate of people leaving treatment is kind of frightening. And so to me, that says, okay,
we got to do something different.
Yes.
Einstein's definition of insanity is doing the same thing over and over and expecting a different result. So especially with people who've, struggled for a while and tried different places, but, the same kind of protocol. Well, let's just mix it up. Let's just try something a little bit different. And I think it's especially in residential treatment for adults who've been struggling for a while, it's so punitive, and they're treated like children, and it's hard enough to do it when you're an adolescent, but as an adult, there's so much shame and stigma for having the condition, for being there, from not being able to heal thus far, and then to just treat them punitively is. We have to do better. Yeah. We really have to do better.
There's people out there trying. There's people certainly.
Absolutely.
Brooke,
there's some wonderful people and wonderful minds out there, and I won't put everything in the same box, but I think we are all different. And we need to be seen as individuals and treated as individuals as best treatment centers can and as best providers can. Because just having people who believe that you can do it and who can see you through whatever illness you're going through can get you going. It can it can be enough to start the healing.
Yeah.
Okay, so why do you think that people do not realize that they're neurodivergent until they're an adult? Why do you think that it's discovered then?
Well, I think lately, especially like with COVID, there was the, social media trends where it became obviously increasingly more common and prevalent, where I think a lot of clients will come in, especially in the therapist community. It's split 50-50 now, but some therapists really hate when people bring in maybe like the TikTok trend of like, there's these TikToks that are mentioning ADHD and autism. Could that be it? And they get very dismissed of it's just social media. Let's talk about something else. But I think because of COVID and the influx of social media and communities and conversations about certain things, traits, symptoms, that's opened the eyes for a lot of people to be curious and do their own self-exploration to try to advocate for this diagnosis. And also what I mentioned earlier, I think lately a lot of people also realize their own neurodivergency. If a child gets diagnosed with ADHD or autism, having the ability to reflect and be like, oh, that was also me as a kid. And I do that thing too. So trying to support their child, they might want to then go to their own therapy and figure out, what they've been dealing with their entire life. So I think it's kind of right now a common here and now thing. And a lot of the assessment tools were created in the 80s and 90s, mostly off of white, higher SES, cisgendered, heterosexual males.
Are you kidding me? Is that the system that was? What? Perhaps we need to be more inclusive in our research. Oh,
So
shocking. I'm glad you brought that up, and I'm sorry to interrupt because it is so pervasive and it's so wrong. And we need to acknowledge that it needs to stop. For far too long, the data that we're using is flawed
And old.
It's flawed and old, and it's not okay. It's not okay, and particularly with mental health.
Right.
Like, come on, people. Okay, I'm done.
We take turns getting on our soapboxes.
No, appreciate someone as passionate as I and enraged when I, really dug into it. Because in my graduate program, when I was in a psychopathology class to learn all of the diagnoses in the DSM-5, I really probably had like a 3-minute spiel on both ADHD and autism combined, where it was more formal than this. But essentially with ADHD, if you're working with this, you probably is in the child or pediatric population in schools. It's the 8-year-old boy running around the classroom, bouncing off the walls. That's ADHD. And if they come to you as an adult, they already have their diagnosis. They're already medicated, so don't worry about it. And in my mind, I was like, okay, I want to work with women's health, eating disorders, postpartum. So, okay. I'm not going to be working with that. And then autism was, okay, again, maybe in the child population schools, they'd get diagnosed very early on, and you'd really see it in this very stigmatizing and stereotypical way, or they'd be in a group home, or, they're more of the Asperger type, like an engineer. So they already have their diagnosis if they do come see you, and that was really it. So I just said, okay. I'm not really going to specialize in that, so I'm not. Need to know more.
Wow, and so many people that developed their own coping mechanisms because they did not fit that box. Right. And, oh, God. And there also, when we associate younger kids and being in school and that being where they figure it out, there also was the pushback of not wanting to know. Like, if it was a little boy and he was running around the room and interrupting class all the time, oh my God, he's ADD. Get help for that kid. But the rest were ignored. The quiet child sitting in the back causing nothing. Yeah. There might have been a lot going on, but no problem. So again, perhaps the system is flawed. Yeah. Dare I say.
So this has been great today. This is unbelievable. This has been so eye-opening for me, and what a great conversation. And I hope the people listening to this will learn more about themselves and neurodivergency from this interview, and how, as a society, can we be more compassionate toward neurodiverse population. I mean, it's just, I always, but for the grace of God, go I, and be thankful for everything you have, and, put yourself in somebody else's shoes and all that stuff. But, as a society, we seem to be, what about me, out there? So how can we, rather than screaming from the rooftops and, making everybody listen to this podcast, how can we be more compassionate?
It's as simple as it is, but it's so hard to maybe really answer it. But just being curious about our own maybe thoughts or stigmas if we encounter maybe something that we might judge or deem not normal, or challenge, like where does this come from? Why am I having this reaction to this thing this person is doing or saying, or why am I upset that they're not making eye contact with me, or they're talking a lot. It could be anything, or, there's so many people too out there. I want to add that are neurodiverse and we have no idea that they have ADHD or they are autistic or struggling with OCD or have a ton of trauma. It's everyone we meet. So it's just, simple as it is to be kind, be compassionate. It's so hard, unfortunately, for us, but we all struggle.
Yeah. I think some of the famous people that have done some of the greatest things, in inventions, from Einstein to Steve Jobs, Bill Gates, and Elon Musk now, they're not your typical personalities out there. So,
Neurodiversity isn't the shameful, stigmatizing thing, that maybe we assume it is or have been taught, the negatives about. Like, we all have beautiful differences in brains.
Hopefully it's okay that I mention those people.
Of course, Jack. You can do whatever you want. It's all good. I have to ask, I have this vision from your training of the umbrella.
Yes.
And the raindrops of neurodiversity underneath.
Yes.
Could you just kind of run that list? Because it was like, yeah.
Well, I can reference, it was created by, they're on social media, but I'll name them Sunny Jane Wise, and an Instagram, I believe their Instagram handle is The Lived Experience Educator. But it's an umbrella and it has a ton of different mental health conditions and disorders. And, I'm naming a lot of the common ones on here of ADHD, autism, OCD. But there's other things on there of dyslexia, traumatic brain injury, trauma, bipolar, borderline personality disorder, you name it. In the, neurodiversity affirming community, they're getting to a point of, if anyone can fall under this neurodiverse umbrella, we're all neurodiverse, and, all of these things impact our brain and brain wiring. We know trauma impacts our brain wiring, even if we weren't born with it. A traumatic brain injury impacts our brain wiring. We weren't born with it, maybe. But just trying to show trying to be as all-inclusive as we can. And if people identify with, no matter what their diagnosis is, we all just see things so differently, and from whatever reason. So,
and sometimes the longer somebody is sick and isn't properly diagnosed and treated, the more labels are slapped on.
Yeah.
And that doesn't do too much for the ego.
No. When we constantly have 7 disorders on our chart, we feel very shameful.
And if maybe the first thing that was listed got treated properly, those other labels wouldn't be there. And I think it's important to remember that, just take one step at a time. And you know what? I think when you're hurting and you're not your best, you could easily be misdiagnosed for a lot of things. We all could be. So,
I think also often people are dismissed. That's because, and just kind of written off. And I think the conversation about kindness and compassion is really something all of us need to reassess in terms of our own reactions to individuals and be more tolerant and more accepting and say, let's find out a little bit more. Let's have a little grace. Let's have some understanding.
Absolutely.
Well, Brooke, thank you so much for this conversation and helping us understand more. It's just so important. We all need to know, and we all have to have that little spark of kindness in us wherever we go and whoever we meet. Do you have a few words of wisdom to leave us with?
Yes. On the similar token that I just said earlier of, being compassionate and patient and give everyone grace and yourself grace. But I think the last thing is just always be curious, not just with maybe what others are doing, but yourself. And also, if you're a person trying to find the right fit for a provider or a therapist, as hard as it can be, like trying not to give up until you find the right fit. And, there's starting to be more and more resources out there, fortunately, to find, someone that can hear you and give you even more information about your experience that you didn't know. So.
Beautiful. Brooke, this has been wonderful. Thank you so much for spending this time with us and sharing your precious time with us. We so appreciate it, and I'm sure our listeners will too.
Thank you so much for having me and having this start of a beautiful discussion. So thank you all.
Okay, I think it's time to wind it down here. Thank you, listeners. Our daughters and you are the reason we do this podcast. And a warm thank you to Rockvox Recording and Production and Scott Fitzgerald, sound engineer extraordinaire, for expertly producing our podcast and so much more.
Help us continue the conversations. Please rate, review, share, and subscribe to Once Shattered on the podcast or platform you're listening to now. Tell your family and friends about us and check out the show notes to learn more about neurodiversity and more about Brooke Ward, licensed marriage and family counselor, and her practice, and more about Jack, Linda, and our nonprofits, KMB for Answers and the Emily Connection.
And please remember, everybody's mental health matters. And also remember that this place here, Rockvox, is the place to record your podcast, which we're doing, record our audiobook, which we did, and do a legacy cast for your loved ones. Scott Fitzgerald is the best. And thank you, everybody, for listening.
Thank you, everyone.
Thank you.